So the case I'm going to discuss is a typical case of a patient with follicular lymphoma. So this is a 77-year-old gentleman who initially presented with a 4-month history of some occasional fevers. He also noticed that he was having a decrease in his appetite, and then ultimately noticed that he had weight loss of about 7 pounds that was completely unintentional. He was seen and evaluated, and upon that evaluation was noted to have a left axillary lymph node that was palpable and measured about 4 centimeters, and then also had a spleen that was palpable at 4 centimeters below the costal margin. In the process of that initial evaluation by the oncologist, he was noted to have a white blood cell count of 10.6, a hemoglobin of 10.1, and a platelet count of 100. His lactate dehydrogenase, or LDH, was 325. His beta-2 microglobulin also was elevated at 3.3. That LDH was above the upper limit of normal, which was 200 for that lab. He had a hepatitis B test done that turned out to be negative, and ultimately had an excisional biopsy of that axillary lymph node that determined it to be a CD10 positive, CD3 negative, CD5 negative, CD20 positive lymph node that was also BCL2 positive and was read by the pathologist as follicular lymphoma grade 1-2. At the same time, he underwent evaluation with bone marrow aspiration and biopsy, and that bone marrow biopsy showed lymphoid aggregates with 35% involvement with follicular lymphoma. Molecular genetics of both the lymph node and the bone marrow showed evidence of the translocation 1418. And he eventually underwent a PET CT scan that showed enlargement of the left axillary lymph node, mediastinal lymph node enlargement, bilateral periaortic lymph node enlargement, with the largest of those lymph nodes being 4.2 centimeters in the left axilla, 5.3 centimeters in the mediastinum, and other lymph nodes that are about 3.6 and 3.5 centimeters, also with a large spleen that had been noted on physical exam. He was diagnosed at that time to have Ann Arbor stage 4 disease with an ECOG performance status of 0. After he completed evaluation, he was initially treated with the R-CHOP chemoimmunotherapy regimen, receiving 6 total cycles of therapy, and then proceeded on to have rituximab maintenance, where he received a dose of 375 milligrams per meter squared, given once every 2 months, with a planned 2 total years of rituximab maintenance. He'd achieved a partial response after completion of his induction therapy, and during his maintenance therapy, approximately 6 months later, he complained of increasing fevers, and then had a repeat PET CT scan that revealed progression of disease, again with a large lymph node in his axilla and other sites of lymphadenopathy. He was evaluated and determined to have relapse of his disease and was started on bendamustine plus obinutuzumab, where he received 6 cycles of therapy and then continued on with maintenance of obinutuzumab. His repeat lymph node biopsy at the time of his relapse also showed follicular grade 1-2 lymphoma, and there was no evidence of transformation. Approximately 8 months after completion of his bendamustine and obinutuzumab, he again noted some increase in weight loss. He at that time was noted to have a second relapse of his disease and was started on idalicib at 155 milligrams given orally twice daily.